Rajesh with the title To the Limit.
Good morning. I am presenting on behalf of Medicine 4. Today I am presenting a spotter. Can anyone? So, coming to the history, the 26-year-old female from Tamil Nadu presented with complaints of skin lesions over the both legs in the shin region for 1 month, joint pain for 20 days, and history of fever for 1 day prior to the admission. So the presenting illness, it's a reddish, painful skin lesions over both the legs. So non-itchy. Lesions increase in size and new lesions develop over the bilateral knee, which is also painful. It also involves the right forearm, elbow, and left index finger. And joint pain started in the bilateral ankle joint, metatarsal joint in swelling, pain aggravated with movements. She had one episode of fever 1 day prior to admission, and he had another episode of fever 20 days before. No history of oral ulcers, photosensitivity, or Raynaud's phenomenon. No sore throat, cough, or cold. No weight loss or night sweats. She had a history of recent steroid intake outside for the same complaints. Coming to the examination, pulse is 86 per minute regular. Vitals are stable. Skin showed multiple hyperpigmented and erythematous skin lesions over the both legs and ankle. So nodular tender skin lesions over the right forearm and erythematous lesions around the right elbow. There's no thickened nerves. Tender joints counts are 5 and the swollen joint counts are 3. She also had right axillary lymph nodes present. System examinations wise were normal. So the syndrome complex is a fever with polyarthritis with erythema nodosum. The picture is of a erythema nodosum. So today I'm going to talk about the approach to erythema nodosum. So the differentials we considered were acute rheumatic fever, reactive arthritis, infections, bacterial, streptococcal, leprosy, viral infections, mononucleosis, malignancies, lymphoma, leukemia, sarcoidosis, Behçet's are all considered. So, approach to erythema nodosum is a primary, which is idiopathic. It's a secondary, which could be lead to many other causes like a bacterial beta hemolytic streptococcus, staphylococcus, or virus like infectious mononucleosis, parvovirus B19, and some fungal infections and parasites can be there. And systemic diseases like inflammatory bowel disease, SLE, APLA, rheumatoid arthritis, Takayasu, and drugs like amoxicillin, penicillin group of drugs mainly, and malignancies like Hodgkin's and non-Hodgkin's lymphoma, leukemia, and sarcoma could all be there. So the differential diagnosis for erythema nodosum, it could be a erythema induratum of basin. This is like mainly associated with tuberculosis. It could be a very well superficial thrombophlebitis, which is present with tender and has the same local pain, induration, and erythema along the course of the superficial vein. Cutaneous polyarthritis nodosa, which is seen as a subcutaneous nodules and located over the lower extremities. Panicleitis like a T cell lymphoma, which is a solitary multiple nodules. It's also present on the extremities and tongue. As the nodules and plaque resolve, they may be replaced by areas of lipotrophy. Erythema nodosum leprosum, which is due to type 2 leprosy reactions. Pancreatic panicleitis could be there. And lupus panicleitis, subcutaneous tender nodules and plaques. So which involves the face. So these are the studies which showed the most common causes for the erythema nodosum, among which the most common is the most streptococcal is one of the most common, and as well as the drug induced is the among all these studies the most common two causes for the erythema nodosum. So this is one highlight where the clinical patient with the suspect clinically erythema nodosum is mostly a clinical diagnosis. Once it's a clinically it was a erythema nodosum, the history which can relate to a possible involvement and the possible diagnosis like a upper respiratory tract infections with symptoms with fever. So it could be suspected streptococcal infections. Patient with recurrent oral and genital ulcers, ocular lesions with an erythema nodosum, you should suspect a Behçet's disease. Patient with diarrhea, abdominal pain, and gastrointestinal discomfort, inflammatory bowel disease, and patient with cough, dyspnea, malaise, weight loss, arthralgia, and X-ray showing a lung infiltration of bilateral high lung lymphadenopathy, suspicion of a sarcoidosis. And patients with fever, night sweats, cough, weight loss, contact TB history, tuberculosis, and patient with malaise, cachexia, lymphadenopathy, suspicion of a malignancy. Any recent medications or vaccines which could be drug related. If there is no other histories, nothing is there, it could be a probably idiopathic. So coming to back our patients, our initial investigation showed a counts of 12,700. Urine routine is normal. Angiotensin converting enzyme was 31. LFT is normal. CRP was 60.6. ASO was 762. And ANA is negative. C3, C4 normal, and rheumatoid factor is also negative. And echo was done, which showed a normal LV functions, no other specific findings. And vasculitis, ANCA is also negative. And lymph node, she had the right axillary lymph node. We did the biopsy of the right axillary lymph node, which is also there's no normal. So based on the approach and the investigations, our patients fulfills the modified Jones criteria. No carditis involvement. She was treated with NSAIDs and started on penicillin prophylaxis or acute rheumatic fever without carditis involvement. So she's 26 years old. She's planned for 5 years of penicillin prophylaxis. Thank you.
Was that one of your first differentials when you thought, or did you think that is unlikely, somebody 26-year-old having rheumatic? Is that a usual age?
No, sir.
Any other questions? One more is it? Sharon. Okay, so the next presenter is Sharon. What is your title?
Untitled, sir. Untitled.
Untitled. Okay.